IBD, you must be very careful. Some people write irritable bowel disease, IBD, and so on and so forth. But in general, when somebody writes IBD, first think of inflammatory bowel disease. Um, Actually, it's a group of diseases which is idiopathic. That is, we don't know ourselves. And there's a saying, it is idiocy on our parts and pathetic as far as patients are concerned. And it's a inflammatory condition of the intestines, mainly large, and of course in Crohn's especially even the small, and of course it is chronic. So in these we have two main disease categories, ulcerative colitis and Crohn's disease. PGs need to know only this, and both have overlapping but some distinct clinical and histological features. There are three other diseases which have been included in this. We'll not go into the details, but most consider these as to be distinct. Some think that they precede even ulcerative colitis. This was some of the microscopic colitis things, but we'll not get into those controversies. So ulcerative colitis and Crohn's disease, right? So these diseases have been known for quite some time, since about later part of the from 1875 onwards, when Wilkes first recognized this condition. Although there have been reports in earlier literature about this, but he was the first to say that this is an ulcerative lesion of the colon, ulcerative colitis, and introduced the term. And actually, after almost 80 years, then you had regional ileitis, or what's known as Crohn's disease now, been published in JAMA. So these are the main lesions. And since then, there's tremendous progress in knowing these diseases. And once these two diseases were recognized, there was almost a flurry of cases in hospitals, especially in the United Kingdom, because more and more people recognize this. In the earlier days, ulcerative colitis was diagnosed more often than Crohn's in all countries. But now gradually, it's almost stabilized with almost equal number of cases. In India, of course, it is stabilizing gradually, right? Now, this is the first person who first talked about ulcerative colitis, and actually it was in 1859. But and his work was later confirmed actually in 1930s, just before Crohn's was described. But Wilkes's autopsy of a 48-year-old woman shows that, she had stricturing lesions and transmural ulcerative inflammation of the colon and terminal ileum. If you go back, it's quite likely that also could have been Crohn's. You generally don't see transmural inflammation of the colon and terminal ileum also in ulcerative colitis. But all the same, he's been credited with identifying ulcerative colitis for the first time. And it was actually refined by Sir Arthur Frederick Hertz and subsequently, from UK. Crohn's disease was first called as regional ileitis, and it was described by Burhill, Crohn, Ginsburg, and Oppenheimer. Now, it's called Crohn's because Crohn's is the first author. And how did they decide the authorship? They said, we'll put it in surnames in alphabetical order. So Crohn's was first, then came Ginsburg, and then Oppenheimer, and the name Crohn's disease came to stay. And that was a good description of what we know of Crohn's disease even today. Now, missing in this paper is the pathologist. He was Paul Klemperer, and unfortunately, he didn't find his name in this paper, but he was the first one to describe the histological changes that you see in what was then called regional ileitis. So you have two things which are under the gamut of inflammatory bowel disease, ulcerative colitis, and Crohn's disease. Grossly, as well as on imaging and otherwise, there are differences. Grossly, actually, both have ulcerative lesions of the large bowel, and in the case of Crohn's, even in the small bowel. And Crohn's, it in fact extends even proximally. You can get in the stomach, you can get in the esophagus. And so these extraintestinal manifestations, especially in the GI tract, are quite common. You can get mouth and tongue ulcers and so on and so forth. We are not talking about the other ones like arthritis, so on and so forth. In ulcerative colitis, there's loss of the hostrations. You can get pseudopolyps and, of course, ulceration. And when it becomes more severe, what's called toxic megacolon, the intestinal wall becomes thin and dilated. Crohn's, on the other hand, you generally have a lot of fat wrapping around it. The wall becomes thickened. There's fissuring or cobblestoning, we'll see. And of course, you can get a lot of fistulae and so on and so forth. But it's not necessary that you see this in all cases. And ulcerative colitis classically begins from the rectum and moves proximally. Whereas in Crohn's disease, it's known to be patchy and affects even the small intestine much more than ulcerative colitis. So if it is patchy, you think of Crohn's. The microscopic changes are almost similar, except that you can get fissuring granulomas in Crohn's disease, but not in ulcerative colitis. So these are the gross changes. These pseudopolyps are nothing but inflamed mucosa lying in between ulcerated areas. So both sides are ulcerated, and one bit is lying, which is inflamed and raised. So it looks like a polyp, but it's not a true polyp. It's called a pseudopolyp. Right, and of course, I'll not go into the details of the others which I've mentioned. And Crohn's, of course, you get cobblestoning of the mucosa. There are distinct endoscopic and other features, which Dr. Desai can tell in the end, and they are graded, and there have been a lot of work done on the endoscopic grading of ulcerative colitis and Crohn's, and the gastroenterologists do a fine job of this, and they help where the pathologist also, and they also know where to take biopsies and so on and so forth. So if you come to the epidemiology, first the disease emerges, then all of a sudden everybody starts diagnosing. So there's an increase in the incidence, and the prevalence also rises. The blue thing is the prevalence. And then the incidence you start, and as more and more cases come, they live, but it's a chronic disease, it goes on. So the prevalence, the number of cases in the population keeps on increasing. And then, of course, it reaches an equilibrium. India has a fairly lot of cases of IBD. And the problem with a country like India is that there's so much of population. Any disease, even if it affects 1%, it is almost equal to few countries in Europe, the population. So we do have a lot of cases, and gastroenterologists are diagnosing more and more cases of inflammatory bowel disease. The expected prevalence worldwide by 2045 is 1%. That's huge. You'll have millions of cases of IBD. So postgraduates who complete your course, you will be seeing a lot of biopsies there. So, and if you see the incidence in our country, there's not very good epidemiological data, but one from Dr. Ajay Sood's group said that there are about around 40 per 100,000 population of ulcerative colitis and Crohn's disease, inflammatory bowel disease, especially ulcerative colitis. And in general, it's believed that Crohn's disease is more frequently diagnosed in the south than in the north, but now it's all catching up. Now, can I ask the postgraduate student, any one of you, anyone? Let's take a second year postgraduate. Who will tell? Indira or Dharitri? Is this normal? This is a biopsy from a colon. At least tell me, there are some eosinophils and some lymphocytes there. Is the inflammation normal or abnormal? Yeah, people can write in the chat group also. Ashi, Subhi, if she's there, or Kiran, anyone. What do you think? Yeah, I mean, can be yes or no. Perfectly all right.
It appears to be a normal.
Okay. Okay, Dr. Deepa says it's increased, and many says normal. Somebody says moderate inflammation and all. And who is E? Somebody written. He is written that it depends on the site of the colon. And that's the right answer. We'll see why. Now you have to appreciate what is normal and then the abnormal ones. Now, when they do a colonoscopy, if you see, this from the ileum, ileocecal region, I'll go gradually into it, and you'll notice goes into the cecum, appendicular opening, and gradually, in the transverse colon, it becomes almost triangular, uh, the inner appearance. You should visit an endoscopy suite, and from the left side, you go to the left side of the colon, you come down, and then you come out of the anal canal rectum. So if you notice, the endoscopic appearance is so different in different regions of the colon. And the gastroenterologist, literally closing his eyes also, he'll be able to tell from which part of the colon he's gone into and seen. And he takes a biopsy from there. So if grossly there are changes like this, microscopically, is it all same all throughout the colon or is it different? Right? So this is the different areas that are seen in endoscopy. So firstly, in general, this colonic epithelium dips down and it goes on the surface. It has goblet cells. It has these absorptive colonocytes, right? And then it may have other cells like Paneth cells, inflammatory cells, and so on and so forth. The mucus is secreted by goblet cells. The colonic crypts are generally parallel to each other, just like endometrium in proliferative phase. And they have an appearance as if test tubes are arranged on a rack. The normal colon will be like this, and they rest on the muscularis mucosae, almost on the muscularis mucosae, right? But if you see the colon from different regions, they look different. For example, this one in the lower down will have, seems to have more goblet cells than the one on top here, right? So I do not know if you can see the pointer. Let me see. Anyway, and see, this part of the colon has a lot more goblet cells than the others. So let's go to the colon. Now, if this is on the right hand side, where that is on the left side of the screen, and on the right side of the screen is the rectum part. Now, if you see the first thing, the absorptive colonocytes are more, sorry, the absorptive colonocytes are more in the right side of the colon, where goblet cells are more or less on the left side of the colon. So there's almost a 5:1:3:1 gradient, right? So 3 absorptive cells to 1 goblet cell is seen in the rectum, whereas it's 5:1 there. That's number one. Then intraepithelial lymphocytes are more on the right side than on the left side. So if you find IELs a little more and it's from the left side of the colon, that's abnormal, but not on the right. Then let's come to the Paneth cells. Paneth cells are derived from midgut. Can anyone tell me where the midgut ends? Any of the first year PG? Anuradha? Avanti? Aman? Anyone? Yeah? I can't hear. Anyone?
Dr. Indira, could you please mute your audio?
Yeah, one of them. Tell where it ends. Well, anyway, it's on the junction of the right 2/3 and the left 1/3 of the transverse colon. So that's the midgut. So up to there you can get Paneth cells. It's not Paneth cell metaplasia. Although there'll be more towards the cecum than there. On the other hand, if you see Paneth cells in the left side of the colon, they're abnormal. So that's important. Inflammatory cells in the lamina propria are more in the right side than on the left side of the colon. So therefore, in that biopsy, if it was from the right side, it would be normal. If it was from the left side, it would be abnormal, right? So lymphoid aggregates more on the right than on the left. So till now, the things that are more often found on the left side are goblet cells. The rest, the inflammation and other things, are more on the right side of the colon. Eosinophils are more on the right side of the colon than on the left. And in fact, the highest number is in the cecum. Cecum, you get a lot of eosinophils. Should not make a diagnosis of eosinophilic colitis or something from a biopsy from the cecum unless you are absolutely certain. So these are the changes that you get in the normal colon. Then this is how the crypts are arranged. I told you they lie on the muscularis mucosae parallel to each other. The gap between two crypts is almost equal to one crypt. So crypt, a gap of one crypt, another crypt, and so on and so forth. This is the normal thing. Sometimes you get hyperplasia of the crypts. They become very tall and all. And it's people have counted it, but you have to just see it through experience mainly. It's about 75 cells you get in a normal crypt, about 35 on this side and that side, each half. So when it becomes 50 or more in length, it's more or less hyperplasia. And this, if you take a cross section, you find somewhere between 20 and 25 cells, right? So every square millimeter has about 100 colonic crypts, and the total area is 2 square meters. Okay. Then when you see the crypts, you may sometimes get these branching of crypts. Now this is an architectural abnormality, but when you see it, a single branch crypt, you don't have to worry. It's part of the normal thing. If you find more than 2 branch crypts, then it becomes abnormal, especially if there's inflammation with that. But there is a exception to this. In children in the pediatric age group, you can find crypt branching more than 2 in your biopsy. Nothing happens. It's part of the normal growing child up to about 9 or 10 years of age. And wherever there's a lymphoid follicle, usually you find a little more branching in children in those areas. So crypt branching, right? So that is one thing. Second, can you tell me what this groove is called? Any first year PG or second year? Anyone? When you
Nominate grooves.
yeah, very good, very good. This is called the nominate groove. When you take a biopsy or a section from the nominate groove, you have to be very careful because you see the crypts all enter the innominate groove. And if you take a section like this, it may appear as if the crypt has branched. You must be very careful, and that's why, if you find one or little two crypts here and there, it's considered as part of the normal. It may be part of the innominate group. But in innominate group, if you see carefully, there may be more than two crypts opening, and so it's more than that. Now, this is a Paneth cell, right? Paneth cell, I told you, can be seen up to the wherever the midgut is, right? So you can see the Paneth cells. What is this cell? Any of the second year PGs? Is this a Paneth?
And enteroendocrine cells, sir.
Yeah. How do you differentiate the two?
So Paneth cells have their nuclei basically, and so enteroendocrine cells have apical nuclei.
Yeah, very good. You see, Paneth cells are larger. They have granules which are well made out, and the nucleus is towards the basement membrane. Enterochromaffin cells, the granules are so small they look as if the entire cell is pink or eosinophilic, right? And you can compare with the eosinophilic granules here. They are not as distinct as that. And the nucleus is towards the lumen. And these cells are much, much smaller than the Paneth cells. They hardly go over up to the crypt lumen. They are smaller ones. Okay, they are enteroendocrine. You can do chromogranin synaptophysin. These are not required, right? So just for demonstration. Now the inflammatory cells, you'll find normally more in the superficial regions of the intestine, of the colonic mucosa, than in the base. So therefore, if you find inflammatory cells near the base, they are abnormal. So if you find more inflammatory cells on top, they are quite normal. Lymphoid follicles up to 4 in low power field is allowed, or in 2 millimeters, if you find 2 per millimeter of the of the colon, it's quite okay. More than that, it is abnormal. And lymphoid follicles are found especially near the muscularis mucosae. You are finding a little higher up, they are abnormal, just like in the stomach. Now, what about neutrophils? How many neutrophils can you see in the colon? Yeah? Anybody? Everybody is silent. Okay. In the
They have
chat,
typed,
it's
they are saying not seen.
some people have written not
So
seen.
normally it's
Definitely.
not seen, 0.
In the stomach and in the colon, you don't see any neutrophils. Neutrophils are always located only within the capillaries. The moment they come out outside the capillaries indicates there's an acute process. If they are normally present, imagine the microbiome and other things in the surface in the colon, the amount of inflammation it would have normally caused would have caused almost a cytokine storm. So nature has made it, they'll all be located inside the capillaries, and as and when required, when there's chemokines and chemotaxis, so on, so forth, when there's an inflammatory process, they come in. And therefore, neutrophils are short-lived, when unlike lymphocytes and plasma cells. So, because they have a short half-life, whenever you see neutrophils, it means it's an inflammation that is relatively acute, or what is called in this IBD parlance as active disease. So first of all, they are not seen. If they are seen, they have a short half-life, so they go away very quickly. And if they are continuously seen there, it's not a chronic process. It's an active process that's going on for quite some time. Okay, so that's it. The neutrophils can be seen in the lamina propria, or they can be seen in the epithelium. What is this called? Any first year? If neutrophils are seen in the crypt epithelium, cryptitis, okay. And in the lumen, it's called
Crypt abscess.
crypt abscess. Very good. So these are the three ways that you look at neutrophils, right? Then plasma cells and lymphocytes you can see in the colon, but the plasma cells, they have more significance because they are seen in these chronic cases and their location is there. Now what is this? I've put one picture. Any first year?
So it's a goblet glass.
Yeah, it's a wine goblet. And if you notice, these are the goblet cells.
Goblet cells.
So that's why they are called goblet cells. Okay, you've seen. And these are the plasma cells right here, which you see. The plasma cells are seen mainly in the, if they are seen near the lower one third of the crypt or between the crypt and muscularis mucosa here in this region, they become significant. It's called basal plasmacytosis. We'll see to that later. Macrophages can be seen, but more often seen in the rectum than elsewhere. They don't have. So these are the changes in the normal. You have seen this. So now that you know the normal, we'll go to the abnormal. Any doubts, anything here? So it also means when you get a specimen, it should be labeled by the endoscopy. This is very important. That's be. Now there are certain other things. The inflammation can be focally increased or a patchy increase. Focally increase is the background inflammation is the same, but all of a sudden you get a localized increase of these inflammatory cells. Patchy increases, the background inflammation is also increased. And then in addition, you get localized increased intensity. Here the background intensity is normal, and here you have what is called a focal increase in inflammatory cells. Here the background inflammation is increased. In addition, you have localized. So this is patchy inflammation. This is very important because these terms are used. You get a patchy inflammation in Crohn's disease. So these terms are used in that. Now the other thing is we have to recognize certain changes in whenever, because the colonic mucosa is prepared by the endoscopist. The gastroenterologist prepares it because there's a lot of, the lumen has to be empty, the mucosa has to be clean. Only then he can see the mucosa well and make an assessment and then take biopsies, right? So there may be changes like the flattening of the colonocytes, the goblet cells, there may be reduction, right? Because mucus is produced as a, if the mucosa feels irritated because of whatever enema or drugs, whatever they give, and if goblet cells may become empty, then if you take a biopsy, you must say there's goblet cell depletion. But you must be careful. You must know in it has to be interpreted in the context of the other changes in the mucosa, right? You may get few neutrophils here and there and extravasation of red cells. So, but nowadays they do a bowel preparation with polyethylene glycol peg or similar substances, and these cause very little histological alterations. It's been a boon to pathologists. Earlier they were using other things, you know. All those people have described changes, but these changes are very few. So you'll be lucky. One change which is common is, you see, from the biopsy, they usually use pinch forceps. They just pinch the mucosa and pull it out like this. So you may get this focal hemorrhage, nothing to get worried about. Many people think, oh, there's hemorrhage in the mucosa, something is wrong and all. So these are common artifacts that you may see, nothing to get worried about. They're usually focal in one or two places. And look, the surface has just been denuded in this area. In this left side, they are seen. So these are certain artifacts that you may get, but this should not help with this. Now, this you find, you see, there are spaces around the crypts. This is a fixation artifact. So it's not been fixed properly, and so you get all these changes. This almost, it retracts away from the basement membrane like that. What is this change? Any of the second year PGs? What is this due to? Anyone? Everybody silent. They muted, is it?
No, they're not muted.
So fixation defect.
What fixation?
Sorry, if the formalin is not properly sourced, or if that it is inadequate form.
They're finding these big spaces, here spaces in the
Bowel
lamina.
wall edema. Bowel wall edema.
Bowel ball edema, air insufflation. You know, these changes are mainly seen when the biopsy is kept in the refrigerator. You know, you get freezing artifacts everywhere. You know, this freezing artifact, do you know why if you freeze a tissue and then thaw it, why do you get these spaces? Well, the water in the tissue becomes ice. Then it thaws. What will happen to the tissue?
Lytic,
Huh?
autolytic artifact.
The tissue break. Oh, this is your school physics. Anyway, it's because 10 volumes of water become 11 volumes of ice. So there's an anomalous expansion of water when it becomes ice. So therefore, if you freeze it, the ice crystals are generally larger. It takes a larger space than what it was initially. And therefore, you get all this. And when there are many crystals, this is what happens. To prevent this, if you want to freeze something, you have to freeze it very rapidly. This happens in a cryostat, or you put it in liquid nitrogen. So that is why best tissue things are put it in liquid nitrogen. That's almost minus, 200. It can breach some of these. So it immediately freezes. There's no time for large crystals to form. They form very small crystals. Same thing in the cryostat. Therefore, there's minimal distortion. In fact, somebody I knew did a slide seminar of HND from the Mayo Clinic. He brought the slides, and in the end, he told all of them were frozen sections. They were as good as our paraffin section. So, you know, you can get very good sections if you treat them properly. Now, what is this? Fat? This one.
So fatty changes.
No, these are the air insufflation changes. It's called pseudo-lipomatosis of the colon. This is because the colonic mucosa, no, they collapse, so they insufflate air, and it's believed some air might have gone in, and that's why this is called colonic pseudo-lipomatosis. It's not a fat because there's no nuclei there. They are a variable changes. Some people say that it's because some earlier people thought it might be lymphatic, so on and so forth. But most probably it's because of air insufflation, pseudolipomatosis. Nothing to worry about. Okay. Now let's see the changes. Now the histological changes in IBD are common. Any non-neoplastic disease, the changes are all same. In the liver, you'll always get cholestasis, any injury, virus, drugs, whatever, cholestasis, necrosis, inflammation, and later stages you may get fibrosis. This is the same thing. You have to, it's a combination of all this. Even post-transplant or a viral infection or hepatitis or CM, whatever it is, they're all similar, only it varies in degree. Similarly, in the colon, whether it is any one of these, radiation, ischemia, idiopathic, drugs, chemical, immunological, the changes are same. So you require a good history and a good gastroenterology friend who will tell you. And only when you do a good clinico-pathological correlation, all of you sit together, then you're likely to make the right diagnosis. And more the information available, better it is. You just walk over to them, they'll tell you if it's not written in the form. Okay? So please remember, sometimes the histological analysis is limited by sampling. And then you have artifacts, red herrings, and so on and so forth. So you must have a clinico-pathological approach or every biopsy, whatever, especially non-neoplastic. In non-neoplastic, you don't have histochemistry to help you arrive at a cellular diagnosis, which is required in tumors. This is much different. So you must be careful in all this. Now, this I need not tell you. The way ulcerative colitis is on top and the Crohn's disease usually is seen below. This is the classical appearance, but you can get changes. So you have to take biopsies from different sites. How many biopsies do you take? It's known that the diagnostic accuracy increases with the number of samples. In any newly diagnosed case, many people follow the rule of two. Two from every side, ileocecal region, cecum, ascending, transverse, descending, sigmoid, and colon and rectum. And at follow-up, from wherever you want, you can take 1-2 biopsies. Long-standing disease, of course, what is ideal cannot be done. It's almost two biopsies for every 10 centimeters. Nobody has the time or anything to do, but I have known people from US, some of my students and colleagues who have come. They say that especially in resected specimens, they are quite diligent about these things, but not necessarily in biopsies. So anyway, basically, you have to take more than one biopsy from each site in different sites. The other thing is, please, it should come to you labeled in different containers. I told you each part of the colon is different, and when there is inflammation and all, get mixed up. So if you put all in one, the quality of reporting becomes less. So please talk to whoever is in the endoscopic suite and do it. We have had a lot of arguments on this when we wrote certain things on IBD with the Crohn's Colitis Foundation and Indian Society of Gastroenterology. So many gastroenterologists felt when their busy schedule and a busy practice, it's very difficult to put them in different vials unless they have adequate help. The second thing is there's an issue of payment, number of blocks, and so on and so forth. But anyway, if you want to do it properly, it's always best to put it in different containers. And this has been, there are various studies to tell you that you must have minimum of 2 biopsies. If you have more than 3, it is always better, and so on and so forth. And you must take multiple sections, 2 to 6, and you take step sections, each containing more than 5. Then you get a good diagnosis, because many things can be patchy. And if you take only rectal biopsy, the accuracy for ulcerative colitis, which affects the rectum invariably, is almost 70% only. Crohn's is almost half that. So you see, there are various studies, not going to these, and it shows that more the biopsies from different sites, the better it is. And the reason why it is that, say, in long-standing ulcerative colitis, the histological disease may revert to normal in certain areas. Sometimes it's patchy, so you miss it with one biopsies. And sometimes endoscopically it may look like normal, but you find inflammation microscopically. And therefore, you can get rarely rectal sparing and so on. Therefore, it's better to take multiple biopsies, right? And especially in treated cases. Now, in biopsies, we are seeing only the mucosa and submucosa. Unfortunately, we don't see the muscle and deeper part, which is important in Crohn's disease. So that's the limitation of these biopsies. And look at how. Now, what is this? Which part? What is this? Anyone can tell? I have been showing you normal and all. What is this area? Anyway, is it the
Mucosa.
mucosa of what organ?
Colon.
Colon, okay. Yeah, it looks like the colon, but it's actually the small intestine. So actually the colonic crypts are like the crypts of the small intestine. They're in the lower part. The difference between colon and the small intestine, actually the villus part which is on top. So you must have well-oriented biopsies. How do you make out they are well-oriented? If the crypts are parallel to each other, almost resting on the mucous membrane. Say that is tangentially cut, but you can give a report on this. It's not that difficult, but this is ideal to see basal plasmacytosis, this and that. This is the ideal biopsy, right? So please note, normal crypts rest on the muscularis mucosae, right? And so there are 7 to 8 crypts per millimeter. So if you find 7 to 8 crypts, like here 1, 2, 3, 4, 5, 6, 7, this is about 1 millimeter in size in a normal biopsy. But just eyeballing, you can make out this is the distance there. Now, what do you see in colitis? It's a crypt destructive colitis. So the crypt is there, it gets destroyed by inflammation. So this is basically what you find in inflammatory bowel disease. But remember, there's a whole list of other diseases that cause this similar findings. So inflammatory cells normally more in the superficial, but in the base, if you see, you find them. After how many days will you find changes? You see, it takes about a week to get the changes since the patient first described these. And but invariably, these patients come to the clinic after a fairly long time. So you will find changes in most cases of ulcerative colitis or Crohn's disease. The response of the epithelium once it is injured is you can see the epithelium destroyed and then it proliferates. So you can see it's regenerating, right? And therefore you get lot of reactive epithelial proliferation. When we come to dysplasia, we'll discuss this. Then the branch crypts are a feature of regeneration. So you can get that in chronic colitis, but it takes several weeks. That means when you see a branch crypt, means the disease has gone on for a long time. And Paneth cell metaplasia, when it is found in the left side of the colon, without much inflammation, it helps you to identify this is a chronic process. You don't see branch crypt, you don't see much inflammation, but you see Paneth cell metaplasia, the left side of the colon, think that this must be a chronic process. So these are the other changes. Then, of course, the loss of epithelial attachment to muscularis mucosae, shortening of crypts, and crypt loss means the crypt has been destroyed. So these are the basic changes that you see. So you will find features of chronicity, which is characterized by architectural abnormalities, metaplasia, inflammation, and stromal changes. Features of active inflammation, that's basically neutrophils and the damage it causes to the epithelium. And there are other features. Okay, so we'll go to these one by one. Mucosal architecture, lamina propria cellularity, inflammation of neutrophils and epithelial. These four things you have to see in the colon. Architecture, cellularity in the lamina propria, see if there are neutrophils and see if there are epithelial abnormalities like erosion, ulceration, so on. If you can concentrate on these four, most of your diagnosis is done. First, look under lobar. You see, this fragment on top shows inflammation, this does not. It is a discontinuous inflammation. Whenever you see this, think of Crohn's disease. Ulcerative colitis, unless it's treated or something, you will never get like this. In ulcerative colitis, it's a continuous disease. All fragments show almost similar. From the same site at least. If you take two biopsies, they will look alike. But in Crohn's, not necessarily. Crohn's, even normal, endoscopically normal mucosa will show inflammation in many. So, and it's all patchy like this, discontinuous. Think of Crohn's. Second, let's go to the other features. Crypt architecture abnormality. The crypt shows different architectures. You see, So one is wide, one is small, all these changes. And there are of course Paneth cell metaplasia and all. If you can see it lower down, here it is. Okay. So let me put this pointer. Pen here. Okay. So you see these here. This is Paneth cell oh God. It's not coming. Laser point is this. Yeah, see this Paneth cell metaplasia. Some crypts are wide, some are small. So this is an architectural abnormality. Think of this. And when it's more than 10% of crypts, it's abnormal. This crypt branching, which we talked of earlier, and look at these crypts. They look like rings. That's almost tortuous, That's why they've been cut across. So crypt branching is abnormal, and I told you, even this is a cystic crypt here. That's also abnormal. All this you get in this. Branching crypts, we have discussed this earlier, and more than two. So this is how you get crypt branching. They're regenerating. They fold onto themselves when you cut across. And please note, if you find lot of crypt branching and total number of crypts which are separate, and branching like that, it is a good way of distinguishing this from infectious colitis. In infectious colitis, you don't get that many crypt branching or crypt fusion and all that like this. You get it in ulcerative and especially in Crohn's disease. There are other changes, see this? Rings of crypts you find. This these are the novel changes that people have described. This crypt branching is symmetrical. This crypt branching is asymmetrical. And here you see budding of epithelium inside the lumen. All these are abnormalities. These are almost like two kissing crypts. And all this is because the way sections are taken from these branched crypts. These are all changes seen in chronic IBD, okay? And good way of distinguishing it from infective colitis. See, crypt has shortened. It's gone up from the lamina, from the muscularis mucosae. This means it's a chronic disease that's been going on for quite some time. See, crypt atrophy. Crypt has been lost. You please note things like this you can get even in graft versus host disease. You have to interpret under a clinical context, right? Okay, so look at this crypt atrophy. You get villus-like changes. This is very important. Irregular mucosal surface you get in IBD. This is another change that you see. Then, of course, this irregularity may be because of ulcerations and erosions and so on and so forth. Right? So these changes you can always get in IBD. Paneth cell metaplasia beyond the hepatic flexure, and this is, what is this change? Any of the PGs? Well, this is pseudopyloric metaplasia. It looks like Brunner's glands in the colon, especially in the ileum. When you think of Crohn's disease, right? In a particular clinical setting. Basal plasmacytosis. Now, basal plasmacytosis is very important to identify chronic inflammation in the colon, right? And the basal plasma cells are found actually in the lowest portion of the lamina propria, and you search for them in between crypts. And the maximum number of plasma cells in between crypts in normal is about more in the cecum, around 7, and in the rectum you can get around 2, not more. So therefore, if you find more number of basal plasma cells, it becomes important, right? And basal plasmacytosis appears within a week or two, and so it's a good sign. And therefore, many people believe the presence of 3 or more plasma cells per width of one crypt between the crypt base and muscularis mucosa is significant. So search for plasma cells. This is very important. And you must learn to identify plasma cells, nucleus in one end, this slightly basophilic cytoplasm, and you search for them, okay? The next thing is granulomas. Be careful, eh? And granulomas, most people consider you can get in Crohn's. Be careful, this is not a granuloma, but a crypt cut across in the base. So be careful. This is perhaps a small granuloma there. And finding a granuloma is very significant finding in this one. This is a tangentially cut crypt base. Please be careful. You'll find, like this ring of almost like a cells around the basement membrane here. So look at this. And the nuclei are not like the macrophage nuclei. But granulomas, if you find when the crypt is destroyed and mucin is there, then it is not significant. You can get that even in ulcerative colitis. What are these granulomas called when they are found in association with crypts that are damaged? Anyone? They are called cryptolytic granulomas.
Cryptolytic.
Cryptolytic granulomas are because of a reaction to mucin, and they can be seen in ulcerative colitis and Crohn's disease. Be careful, because in usual Crohn's disease also many granulomas are found next to the crypt. So you must be careful. It's not because of that. There's a nice submucosal granuloma, right? You see this. Now the question is this tuberculosis or Crohn's? This is always a problem. How are the tubercle granulomas? Tuberculous granulomas? Any first year PG can tell?
Caseating granuloma necrosis.
Okay, there are two or three things. One, they are usually large. Second, they are confluent. See, two granulomas are joining together, right? You may find in a granuloma two giant cells system. It means there are two granulomas that are joined together. Then second is they can be necrotizing, and the type of necrosis is caseous necrosis. Of giant cells. These are all confluent granulomas. Even though there is no necrosis, they are suggestive of tuberculosis, unlike in Crohn's. In Crohn's, you get smaller granulomas. They're more discrete and non-necrotizing, like this, right? They're small granulomas. Now, what is small and what is large? See, conventional granulomas consist about 25 epithelioid cells, right? Or they are more than 2 crypt width. 2 crypts, the same width as that, 0.2 millimeters or 200 micrometers in size. Granulomas smaller than 2 crypt width are called microgranulomas. And more than 5 histiocytes at least must be present to call it a microgranuloma. And that is very typical of Crohn's disease. So small granulomas, less than 2 crypt width, having less than 25 epithelioid cells, at least 5 histiocytes, they are called microgranulomas. Now, granulomas in Crohn's are non-necrotizing, non-confluent, pericrypt, right? They are not found in the lymph nodes. So in a resected specimen, if you find in the lymph node, very unlikely. In a CT scan, you find a large necrotic lymph node associated with small granulomas, more likely to be TB, right? But very difficult. Not all cases of Crohn's you will get biopsy granulomas. In biopsy endoscopies, you may find in less than 25% of cases. You get them more often in pediatric biopsies, and they are more common in distal colon and rectum, but can be found in stomach, ileum, esophagus, anywhere. And it doesn't mean that if you don't find a granuloma, you can't call it Crohn's disease. You can call it based on other findings, right? And if you have repeated sometimes you have to take repeated colonoscopies. The yield becomes much higher, and more the number of biopsies, more the likelihood of getting granulomas. More the serial sections you get, more. You know, my good friend Anna, who is a wonderful GI pathologist and world-renowned authority on IBD, I asked her, they have a welcome research group in CMC Vellore, doing wonderful job, and she does a lot of these IBD biopsies. She once told me almost she takes 10 to 15 slides on each case of IBD, and that's why their yield of granulomas from CMC Vellore is much higher than anywhere else in our country. They do a very diligent and good job. So the more, even we have seen, when we take multiple sections, the likelihood of getting a granuloma in Crohn's disease is more. So please do that, okay? And in surgical specimens, you're more likely to get than in endoscopic biopsies. And please note, granulomas are considered to be prognostic in the sense that many say that if you find granulomas, likelihood of recurrence and this and that are there. Okay, but they don't mean that the disease is active, unlike neutrophils. So this is very important, right? So, and in Crohn's, you get this focal or patchy inflammation, unlike ulcerative colitis. Sometimes in ulcerative colitis and Crohn's, you get only lymphoid follicles that are very prominent. More than 2 lymphoid follicles per millimeter of biopsy, or 7 or 8 crypts will be 1 millimeter. So in that is called, it's significant. Some mucosal inflammation, significant, mostly in Crohn's disease. Okay. Now, is this an aphthous ulcer? Can anyone tell me? Is this aphthous ulcer? What is an aphthous ulcer?
Lesions present in oral mucosa or even in the esophageal mucosal lining.
That's fine. That's one thing. In the colon, aphthous ulcer, which you get in Crohn's disease. Anyone? Well, many people think it's small ulcer going like a volcano, that is aphthous. Endoscopically they make out in a way that is described, you see. But you call something as an aphthous ulcer when the ulceration is over a lymphoid follicle. That is the histological definition of an aphthous ulcer. An ulcer over a lymphoid follicle is called an aphthous ulcer. Erosion or an ulcer, mainly an erosion above a lymphoid follicle, is called an aphthous ulcer. So this is a lymphoid follicle, this is an ulceration. So this is an aphthous ulcer histologically, right? Otherwise you just call it ulcer. Then of course these other changes, like you see, crypt abnormalities, panel metaplasia, can get in Crohn's. You can get similar features in Crohn's of activity. This is important, unlike granulomas, for activity, right? And then of course ulceration and other things. And see here, goblet cells have been lost. If it is from the rectum, it becomes very significant, right? You get villus abnormality. See, these are all same changes. Now, so this completes what are the histological changes. Please remember, in all active cases of ulcerative colitis, you must look for CMV. It is a must, whether or not it's written there. You can do nowadays, you have fancy immunohistochemistry, you can find out. Otherwise, look for CMV, especially in the endothelial cells in the granulation tissue. You see this nucleus, it occupies nearly 75% of the diameter of the nucleus, and there's almost a halo around it, almost looking like an owli. So that is a cytomegalovirus. Cell is enlarged also, right? So this is what you see in Crohn's disease. Discontinuous mucin preservation more than ulcerative colitis, focal cryptitis, epithelioid granulomas, small ones. Now, in our country, the problem is always between tuberculosis, other granulomatous. Pulmonary pathology, it's always between sarcoidosis and TB of the lung. It happens to clinicians also. Same case. But this study from Vellore is so good. they have found that if the granulomas are concentrated around the cecum, ileocecal region, and just the ascending colon, think of tuberculosis. If the granulomas are everywhere, including the rectum, think of Crohn's disease. This is really an excellent way of telling you what it is more likely to be. It's not absolute, but at least it tells you most of the granulomas are found here, but not in the descending colon and all. Think of tuberculosis. But if it is found everywhere, and also in the ileocecal region, think of Crohn's, especially if you find in the rectum. So this is one way, grossly. Granulomas in tuberculosis are larger, more than 400 microns. Granulomas in Crohn's. So this study was even we have published also, the American Journal of Gastroenterology, our study, and also the CMC study. We found it's almost similar. Less than 200 small granulomas, non-necrotizing, mucosal, pericryptal, and focally enhanced colitis. These are more common in Crohn's disease. Okay, and tuberculosis, more you can get granulomas with caseation. We will see to it large granulomas, more than 5 granulomas per segment, and granulomas in the granulation tissue in the lymph nodes, more likely to be tuberculosis. So this is the finding in one. Now you see, Velo did 2 studies in us, and the findings are almost similar throughout. 5 granulomas per biopsies, large granulomas, and ulcers, and so on and so forth. These are common changes seen in all cases of Crohn's versus tuberculosis. Right? The sensitivity and specificity of caseation necrosis for tuberculosis is almost 100% in tuberculosis, Crohn's differentiation, but sensitivity is low. Confluent granulomas quite specific for tuberculosis. Ulcers lined by epithelioid cells is also quite specific for tuberculosis. Right? Now, you can do a PCR for this one, but it varies on the kit that you are using. You can try it, but sensitivity and specificity, sensitivity is always low. It's about 40%, although it's quite specific. People do gene expert and it's quite specific. AFB smears, this is from the Bombay group and from other parts of our country. You see, it's very difficult. The AFB culture also, you get, some people have done it, it's good, and some people haven't. So it depends on how diligent you are. Up to 20% of the cases, you can get smear positivity in tuberculosis, but it can be as low as 2%. So that's difficult. Now, if you are in a dilemma, what do you do? If the histology is typical, the endoscopy is typical, usually the gastroenterologist will give the specific treatment. If the endoscopy and clinical features are very typical, histology is suggestive, it might be, then also treatment is given. But if one of them is equivocal, then of course you follow up, and if it's not typical, you have to find other causes. What are the unusual features? It is because of treatment, remission, and other things. We'll go to one of them. One is you get very early onset IBD in children, especially below 6 years of age, below 1 month of age in the neonatal and infantile period, even early. Now, this could have a genetic bearing, and they lack characteristic features of ulcerative colitis or Crohn's disease. And that's why they are often called IBD unclassified. And more likely that entire GI tract can be affected. And Crohn's disease is more likely to be a pancolitis rather than concentrated near the ileum and so on and so forth. And they are less likely to be stricturing when they have this very early onset IBD. So this is one unusual features in IBD which you get in children. Then, of course, the Then the other thing is skip lesions. Ulcerative colitis, I told you, no, it goes from distal to proximal, no skip lesion. But you may get skip lesions, especially in those who have been treated. You may get skip lesions in children. And in fact, the rectum can be spared, which is actually against the rule of ulcerative colitis. Rectal is invariably involved. So these are the two places you must be careful, children and when they are treated. And you must be very careful that sometimes you can get skip lesions also around the appendix. Rest of the colon is unaffected. So various studies have shown rectal sparing and patchiness in about 10% of cases of ulcerative colitis. Right? So in endoscopy, the findings are higher because it may almost look like normal, but histologically, when you do a proctocolectomy, only 5%. So that means microscopic changes often are seen. You may not see the changes on endoscopy. So, but you do get skip lesions and rectal sparing, right? Appendix may be involved in ulcerative colitis. And this has been found in colectomy specimens and often patients with refractory disease. Now, it's very interesting. There's been a meta-analysis of 19 studies, and in some studies, appendicectomy was found to be protective. So that means if you do an appendicectomy in childhood, you don't get an inflammatory ulcerative colitis. But there have been studies which show appendicectomy before or after diagnosis, it doesn't affect the severity of ulcerative colitis. So it has to be done long time ago. Few studies have shown that there may be no significant difference in surgical treatment rate for ulcerative colitis once appendicectomy is done. But by and large, there's a general belief that appendicectomy protects against ulcerative colitis. Now, backwash ileitis, the ileal changes are not common in ulcerative colitis. They favor more Crohn's disease than ulcerative colitis. They are usually mild villous atrophy. You get inflammation with neutrophils, crypt abscesses, and they confined to the mucosa, right? So that you can get. Please note, in many cases, backwash ileitis is because of concomitant intestinal infection. And you must look for other agents. Whole lot of agents are there. And it may be because of vasculitis and because of drugs and so on and so forth. So keep that in the back of your mind if you are finding backwash ileitis, which cannot be explained by the disease, right? Granulomas you can get rarely in ulcerative colitis. Most of them are cryptolytic. Sometimes it may be because of drugs, superadded infections, and so on and so forth. And they are indistinguishable from Crohn's disease. Upper GI involvement, more common in Crohn's disease than ulcerative colitis. That is why many feel that when you are suspecting Crohn's disease and some symptom is there, do an upper GI endoscopy and take biopsies from there in addition to the colon. And in children especially, it's good to take gastric biopsies also with the colonic biopsies, right? So please remember, you can get in ulcerative colitis, but less often than in Crohn's disease, right? So you can get upper GI changes in the esophagus, in the stomach, and so on and so forth, right? Some cases of Crohn's disease resemble ulcerative colitis. They are limited to the mucosa. They don't go deep, the inflammation, just like ulcerative colitis. But these patients are generally younger, about 10 to 15 years of age. And generally, the proximal colon is more affected than distal colon, right? And almost half of them will have granulomas. So that will help you in seeing ulcerative colitis like Crohn's disease. In Crohn's disease, it's transmural inflammation. In ulcerative colitis, it is mucosal inflammation. So whenever it's mucosal, but it's Crohn's, it is called ulcerative colitis like Crohn's disease. See, transmural, it affects the muscle. Muscle is a permanent cell. It cannot form, so you get scarring, and that's why you get strictures in Crohn's disease. You also get fistula and all because this transmural inflammation. You can get overlapping features of ulcerative and Crohn's as you have seen in this. So it's very difficult. And approximately 20% of cases of indeterminate colitis. Please note, you must use the term indeterminate colitis only when you examine a resected specimen and you're not sure it's ulcerative. But invariably, most of these, if you these cases turn out to be Crohn's disease rather than ulcerative colitis, right? Sometimes ulcerative colitis can show transmural inflammation, and this is seen in severe or acute ulcerative colitis, which is called, what is the name for this? You can get fulminant colitis or fulminant ulcerative colitis, right? So that is what. What is this condition? You see lot of lymphoid follicles, but it's not ulcerative colitis. This is typical of a condition called diversion colitis. That is, for example, Hirschsprung's disease. You have made a colostomy, the remaining portion of the colon is still remaining. You're doing a two-stage Duhamel procedure, one of the surgical procedures. You have made an ileostomy or colostomy for some other purpose, and the remaining colon is remaining there. In that colon, because of a change in the microbiome, the short fatty acids are not there, and lot of changes. There is lot of lymphoid hyperplasia, and that is typical of what is called diversion colitis. So in such cases, please ask, is this a part of the segment of the colon that's still remaining inside, distal colon, or not? And if they say yes, we have done a colostomy on this, so that becomes a diversion colitis. So you see, it looks almost like ulcerative colitis or Crohn's disease, prominent lymphoid follicles. Then you have to identify dysplasia. Please note, whenever there is regeneration and all, you can get dysplasia. There is a risk of colorectal cancer in ulcerative colitis. It's about 20% in 30 years. In Crohn's disease, it's about 10% in 30 years, more in ulcerative colitis. There have been studies, I think Dr. Desai has done this study, and it's about 3% in 20 years in India. This from the Bombay group with Dr. Desai, Dr. Shah, Dr. Philip Abraham, and so on and so forth. So you see, it's about 3%. It occurs, but we don't recognize it that very often. Familial history and so on and so forth. So how do you detect dysplasia? You have to do frequent colonoscopy, and you have to examine. Then there is a regular system of surveillance in chronic ulcerative colitis, especially in those cases that have been going on for 8 to 10 years and 15 to 20 years for left-sided disease. You have to take multiple biopsies, as many as possible, right? And dysplasia, sometimes it is raised. This dysplasia-associated lesion or mass, this term is no longer used. So you can get like a polyp or raised or elevated area or ulcerated area or flat area, and then you take biopsies from there. Negative for dysplasia, when there is cryptitis, cryptabscess, ulceration, stay away from diagnosing dysplasia. Please, if there is surface maturation, it means there is no dysplasia. Please remember that. So this cannot be, don't diagnose dysplasia in this, although the crypt in the right hand side, these are looking little hypochromatic and so on. There's surface maturation, that's fine, and there's a lot of inflammation. Stay away from calling it dysplasia. Indefinite, you are seeing more atypia, but there's inflammation, ulceration, and so on and so forth, and you're not very confident. So you seek a second opinion, but still it might be called indefinite for dysplasia. You see, the surface is showing little changes, but a lot of inflammation, looks like granulation tissue here. So you're not very confident. You can call it indefinite if your colleague agrees with you. Low grade dysplasia, when there is no surface maturation. In dysplastic epithelium, there are two things. It is all of a sudden, there's a distinct between normal and abnormal area, and the surface is not matured. And then you see the nucleus, hypochromatic and basal, or so on and so forth. Right? So you see these nuclei are definitely abnormal. Will not go into the details. They're becoming, chromatin is becoming more loose, and so on and so forth. High grade, you see, they'll be normal and abnormal adjacent to each other, and of course high grade nuclei. These are high grade dysplasia. See, it's almost abrupt, it's not gradual. You don't see it in high grade dysplasia. In all dysplastic, normal and abnormal are almost side to side, like see this area. Normal, it just becomes abnormal here. See here in this area. So this you get in dysplasia. And surface will be abnormal. Look at the surface always. There are other types of dysplasia people have described, including sessile serrated like dysplasia, dysplasia with Paneth cells and all. These are only for the specialized people. But remember, there are other types of dysplasias that have been described. Please remember, in ulcerative colitis, you can also get the usual adenomatous polyps if a patient has got those genes. So it's not necessary that ulcerative colitis you will get dysplastic changes just because of the ulcerative colitis. It may be because of other reasons. So these are tubular. So please look at the usual cytological changes that you see in other dysplasias. They are same in ulcerative colitis. Now you have to say whether it's dysplasia, indefinite for dysplasia, low grade or high grade. Depending on that, the clinician will follow up or do the resection and other things. So these are various studies that show even in Asian ulcerative colitis patient, the risk of colorectal carcinoma are like those of the West. And we have also done some follow-up studies and we have found it same. So the cancer in IBD, please remember, it's inflammation related. You get colorectal carcinoma, small bowel adenocarcinoma, you can get lymphoma, anal carcinoma, cholangiocarcinoma. Immunosuppression related because you give therapy, right? In that you can get lymphoma, melanomas, urinary tract and cervical cancers. So you can get different types of cancers in IBD. Now you see all these look alike, right? But they are different lesions. These are all ulcerative colitis. This is infectious colitis, sigmoid diverticulitis. All look alike, except maybe in ulcerative colitis, the crypt architectural changes are much more than the others. But they all look alike. So you can miss the other. And in remission, they all look alike. And this almost looks like the normal color, right? So therefore, the gold standard for diagnosis of inflammatory bowel disease is not a single one. It's not that histology alone can help it. So it is a combination of clinical features, endoscopy, imaging, histopathology. Always talk to your gastroenterologist. You have, in fact, I always tell this. Evening cup of tea was always with GI surgeons and gastroenterology colleagues. You talk to them, you can discuss the case, and all of you have to sit even with the radiologist sometimes to make a diagnosis. Now, how do you repair? I report these cases. Same mucosal architecture, lamina propria cellularity, neutrophils, and epithelial. These are the 4 things that are required in your report. Is the mucosa inflamed? No or yes. Any features of IBD? You favor IBD. If it is quite certain IBD, call it ulcerative colitis definite or Crohn's definite, whichever. Or if you're not sure, whether you favor ulcerative colitis over Crohn's or Crohn's over ulcerative. When you can't make out, you call it undefined. Okay? Inflammatory bowel disease, undefined or unclassifiable. Don't use any other terminology, right? See, I told you the other terminology that you use is only indeterminate colitis you will use only when you get a surgical specimen. You don't use it in endoscopic biopsies. Write it unclassified, right? So you have to tell the clinician, give a diagnosis, see if you can distinguish between the two, if there is dysplasia or not, or if there is any other complication, and give the disease activity and disease extent. If the rectum is involved, the transverse colon is involved, ascending colon is involved, and so on and so forth. Please note, most of the initial biopsies, the endoscopy and the histological areas of inflammation will coincide. Once treatment is given, that is less unlikely. Take adequate history, take samples in different areas and do multiple sections. There are various mimics, will not go into this. Please don't use the term non-specific colitis. People will hate you for that, right? You describe it and write whether it's chronic colitis or not. Now, of late, there are good drugs for treating ulcerative colitis, Crohn's disease, and there are various ways. So histology is used to know whether the disease is clearing or not. And gradually there will be molecular targets, which is not yet defined. So earlier there was clinical targets, endoscopic targets, now there are histological targets, and later you have molecular targets. Now histological targets are defined by scores, right? So the earlier scores was actually endoscopic scores. Now you have a whole lot of histological scores. Now for ileal biopsies, how do you score? You have to score from the most affected area. Now in colonic biopsies, it's not sure whether you have to give the score of the most affected segment, mean of all the segments, or sum of all the segments. This is not well defined, as far as the colon is concerned, and many people use different things, right? So it's very difficult, colonic scoring, and that's why most of these scoring systems are not validated. In ulcerative colitis, for example, there are about 30 scoring systems. It's not that validated except about two of them, right? Same in Crohn's disease. There are about 14 systems and 13 indices, and not all have been validated. If they are, they're all partially validated. You know who this gentleman is? Is Karel Jobs. He is from Belgium. He started, they were earlier scoring systems. He refined them actually. There are scoring systems for ulcerative colitis and Crohn's disease. They're quite elaborate, grade 0, 1, 2, 3, 4. Whatever is the highest, you give that. For example, severe diffuse multifocal abnormalities, you give for the architecture 3, like that. So you give 1.3, 0.3, 2.8, and so on and so forth. There are almost 5 different things, actually with subgroups A and B in 2, which are used. Same for Crohn's disease. In Crohn's disease, number of biopsy specimens affected is included and presence or absence of granulomas. So this is how it is done. This is GBOS grading scale. So the GBOS score, you have to give highest grade or sub-score. And if it is more than 3.1, it is active disease. And continuous GBOS score is you just add all of them up. And there's a simplified version of this, right? So it's basically same. Inflammatory activity, plasma cells, eosinophils, neutrophils, and epithelial injury. Then what happened was, these were all refined. These are two elaborate, although many people use it. You have what is called the Nancy histological index. You know why it is called Nancy? There is no Nancy author here. No, it's called Nancy because it was from a place called Vandever-le-Nancy, that is near Lorraine, University of Lorraine in France. So they devised it, that's why it's called Nancy's histological index. What do? First look for ulceration. If it is there, yes, it is grade 4. If it's not there, look for acute inflammatory infiltrate. If it is there, moderate or severe, it is grade 3. If it is mild, it is grade 2. No inflammatory infiltrate, look for chronic inflammatory cell infiltrate. Moderate or increase, it is grade 1. If it is no or mild increase, it's grade 0. Very simple, very reproducible, simple. Look at ulceration, inflammation, acute, inflammation, chronic. That it for. So this is Nancy histological index, right? Then there's another one called Roberts histological index. Roberts histological, why it is called Robert histological index? It's called Robert is because it was from Robert Research Institute in Canada. Okay, so we are just finishing it. You look at chronic inflammation, lamina propria in neutrophils, epithelium erosion, and you multiply by 1, 2, 3, and 4, and you get an index of this, right? So this is Robert histological index. And for Crohn's disease, there is an IBD-DCA index, which is dependent on the distribution, chronic features, and activity. In the same one that is being done here. So please note, nowadays more and more this is required, and these are the indices that are there. Some people have started doing Claudine immunohistochemistry. If it is positive, it means active disease. See, grade is qualitative, score is numerical, index is overall. You have to add them. How do you report? Pattern, activity, interpretation, and dysplasia. So you say the pattern, which site is involved, continuous or discontinuous, and whether diffuse or patchy. Activity, mild, moderate, severe, sites involved, and maximal activity. Write about dysplasia, low or high grade, which sites are involved. So this is how you can write just 4 or 5 lines. The diffuse chronic colitis involving sigmoid colon rectum, mild activity in the rectum, IBD strongly favored over UC, no dysplasia. This is all you need for different kinds of biopsies. So finally, in pouchitis, sometimes they make a ileoanal pouch for ulcerative colitis. It causes inflammation, and the inflammation is more as the time goes by. There is a pouchitis score when the inflammation is there, same like ulcerative colitis. So this is what is done. So interpretation of colonic biopsy relies on interpretation on biopsies from other sites. You must know the normal. All fragments and section must be evaluated to detect focal lesions. Endoscopic biopsies must be labeled separately. And please note pathological correlation. Thank you very much. Sorry, it went on for a long time. I had to cover everything.
It was a wonderful lecture. Now I invite Dr. Desai to get answers for their report.
Sir, it's
So
always a
this-
pleasure to listen to you.
Sir,
Anything, Dr. Vijay?
Yeah. I'm telling. Can you hear me?
Yes, yes.
Yes, sir. It's always a pleasure to listen to you and learn from you.
No,
Actually, I
anything
mean,
you want to add?
no, nothing. There are few questions which actually I saw in the chat thing.
Please tell
Some
me.
of the queries, they said they don't get site-specific biopsies, which I
Okay.
What I feel practically, during my reporting, we do get a lot of issues in orientation, which makes interpretation much more difficult. It's not, we don't really get those typical test tubes in the rack kind of appearance. So we need to educate our technicians and then try to help them orient the specimen very well. The
Dr.
practical issues.
Dr. Vijay Shankar, some people say that you must keep it on a filter paper or anything, but sometimes it
Nothing
is
works.
difficult. It is
Yeah,
difficult.
true.
So what we do know, if it is with the muscularis mucosae, it is easy.
Easy,
Pediatric
yes.
biopsy is difficult. What happens is with the muscularis mucosae, it becomes like a U or a C. The concave part is the muscularis mucosae part because that contracts, and the
Gotcha.
mucosa part is the convex part. So you tell your technician to straighten it and do it. So that's Sir Desai, sir. Anything you
Yes.
want to
Uh,
from the clinician's point of view,
so
sir?
the as usual, very nice, and you have really taught us the basics of histology in IBD. Very useful, and I would think that not only the pathology student but gastroenterology students also actually should listen to this lecture carefully, not once, twice, but till the time they understand properly, because everything is nice. Second thing is, when we usually have what we call as GI pathology meetings. Of course, gastroenterologists benefit more than the pathologist, but we do give history as well as site of biopsy, as it was mentioned that many times the specimens are not labeled. So during that meeting, it can be clarified, because what happens is usually the residents are in a hurry when they have to do endoscopy. Then write the pathology form. So this is opportunity to clarify the doubts before actually finalizing the report sometimes. So very nice. And as
Sir,
I
anything you feel the pathologist must do to help the clinician?
yes, as you mentioned, non-specific colitis or non-specific terms should not be used, because it's really it doesn't take
It doesn't help.
yes.
Yes.
So, and only that thing, but otherwise, these things are clarified in the joint meetings.
Right, sir.
And
Sir, what is your take on serology in IBD? Because we do get requests for P-ANCA and ASA, especially when there were some confusions in the diagnosis on endoscopy. And we also, during reporting, we couldn't convincingly say whether it is, ulcerative or Crohn's. So, do you really request for serology studies?
in general, now serology is out.
That's nice.
So
So
there
there is a
are
question. Yeah, how to say it is mild, moderate, or severe? Can you share cutoff points?
See, there are no distinct cutoff points. Mild, moderate, severe. The severe ones, the entire lamina propria is filled with cells, and mild is a little more than what you get in normal. They, for the sake of some research and all, people do count and all that, but it's not possible in routine thing. So it's mainly done by experience and
Yeah, it's more of
eyeballing
a
and all.
subjective grading, right,
More,
sir?
it is more subjective.
We generally look into less than 5% of the crypts you have cryptitis, we call it as mild. And if you see ulcers and if you see erosions along with diffuse
Those in the
neutrophils,
scoring systems, they are defined. If you
yeah,
go through them, they are well defined in that. But in general, don't. Somebody said
don't.
scoring should be done in treated or untreated. You do in both. Treated as well first time, everything, and give it to your clinical colleagues. See, our basic intention is to help the gastroenterologist manage the patient. Whatever he requires, somehow we have to see, and whatever studies have been done, it's all aimed so that the patient gets the best possible treatment. And in that, if scoring is helpful, this is helpful, that is helpful.
I have
So that's very important.
I have two questions.
Yes, sir.
One is now gastroenterologists are trying to use this this technology called confocal laser
Yes, sir.
endoscopy.
Yes.
So which actually real time these cells can be seen and appreciated.
Yes, sir.
So that is one question. What do you feel, Professor Dattagupta?
Sir, confocal has been is helping, and especially in dysplastic lesions and all, they're able to pick up these early lesions. Supposed to be much better. They're doing with histological changes. Sometimes it's very difficult to make out. So all these early lesions and changes, they are able to pick up, and maybe actually not all centers have it. Gradually they will have it.
We don't have it. It's very expensive.
Very expensive.
Yeah,
Yeah.
more than 1 crore or so.
Mm.
My second question was, now everywhere there is AI.
Ah,
So after 10 years, do you see that AI will be reporting and you can just check whether it is right or wrong?
sir, AI is there. There is a scoring system which is called the Picasso scoring system.
Yes.
There's a Picasso scoring for endoscopy. It was held in a hotel, Picasso, near Piccadilly in UK, so they called it. And that's been extended to the histology. So that is more or less AI based. You put the slide and it does a reading and you get a score out of it. It's being validated. The problem is validation. Maybe later it will do. But the problem is, sir, you require very uniform sections
Yeah.
and other things, which technically we also have to improve. Others, a little thicker section, it'll pick up more cells. Little thinner sections, it'll pick up little less cells. So it has to be validated, standardized with all that, and then it will come, sir. AI will augment the pathologist just like the endoscopist.
Yes.
Whether it replaces, we don't know. Later on,
No,
we
no,
may
I
all
don't
be
think it
out
will
of job.
replace because it's not going to be possible. There has now we have first seen the advantages of AI, and now we are seeing lots of pitfalls of AI also.
Oh, yes, yes, yes. That's true.
So, all right.
That is
Yeah.
true.
I think Dr. Adil has asked this question twice. Can diagnosis of IBD be conclusively made on endoscopic biopsy?
Yes, yes. Ulcerative colitis, Crohn's, you can make. That's why you have a thing called ulcerative colitis, definite, and Crohn's disease, definite, histologically. But you know,
He also asked if the
it has to be
endoscopist is
correlated.
suspecting
It has
IBD.
to be correlated with the endoscopy and all. Finally,
So the question is, if the endoscopist is suspecting IBD
ah,
and we see patchy chronic active inflammation,
yes.
but no granulomas or any other features, what is that we should report it as?
Describe it, and you sit with the endoscopist and discuss with him whether he should start on this one on therapy or not. Invariably, they'll follow up such cases and see what has happened. First thing is they'll exclude infective and other things, and then they will do it.
So it is more of
Is it somebody has written, Dr. Deepa, infective whether IBD can you make? Yeah, in some cases you can make. Infective is usually acute. So if you see basal plasmacytosis, lot of this branch crypts and all, is more likely to be IBD than infective. And but we have made mistakes. There was one of our pediatric colleagues' relative. It turned out to be some Campylobacter jejuni affecting the colon, looking like IBD. So so those mistakes are there. All pathologists make mistakes. Please remember that. Okay. So sir, can diagnose IBD be conclusive made? Okay. We see patchy chronic but no granulomas. What should you have to describe and say that indefinite for IBD or something? In what other condition do you see chronic active colitis? Oh, you can see in radiation, you can see in ischemic, you can see in infective, many conditions. Even if a single crypt is showing neutrophils, is it significant? Yes, it is significant. Infective versus IBD, it's always possible to differentiate on small biopsies. No, not always. Sometimes it is easy, sometimes it is difficult. What is surface maturation? Surface maturation is when you get mature cells from the crypt and going on the surface like this, this entire thing. This should be mature. Surface should be mature. In dysplasia, the surface cells are important. They are not mature. In regenerative and reactive, these maybe the lower cells may be wonky, but the surface will always be normal. Okay, so this is surface mature. Can we use Nancy for both? People have used. What is histological features of irritable bowel syndrome? Generally, we don't see much changes. Sometimes lymphocytic colitis and all have been seen, but not. Which scoring system is better for CD and UC? Many people use Jobis scoring system, or they use this the other one, DCS scoring system, distribution and chronic inflammation activity, which can be used for CD and UC. So you have to sit in your own institution and find out what is best. Okay. Anything else?
No more questions. Should scoring be done only on biopsies of treated cases, or it should be
No, it is
reported on?
done even on the first case. That okay.
Sir, it was a wonderful lecture, a wonderful session. Thank you so much, sir.
No, it's my pleasure, and I hope I have not bored you all, and I hope the students have learned something and not got overwhelmed.
So there are so many praises, sir. Sir, all of them have sent so many claps and praises to you.
That's all.
Yeah, the recording will be available till Sunday, I suppose, right? I think all the residents should make the best use of this.
Yes,
Go
sir.
back and then watch it again, learn.
Adil has written what to do if biopsy bits are not properly oriented. You take deeper sections. Sometimes it helps. Okay? Sometimes it helps. And I've been honored, with Dr. Desai and Dr. Vijay.